Hey, thanks Aditya, Vijay for having me for this evening session on lung cancer, and I thank AstraZeneca for uh, having me for this. My session will be on the role of chemo and IO in small cell lung cancer. Uh, we've heard chemo and IO in non-small cell lung cancers, but it is slowly catching up in small cell lung cancer. As we know, our hands-on experience with small cell lung cancers is not that much because the incidence of small cell lung cancers are very less as compared to the non-small cell. My literature, it's around 15%. 50% of them have brain metastasis, the median age at 70 years, and almost a disease which is seen in smokers, close to 97%, only about a small segment, about 3 to 5% are seen in non-smokers. Um, what is disheartening is 2 out of 3 patients present with extensive stage, which do not fit into a single radiation portal, and these patients tend to have a poorer prognosis, and all these have to be managed with systemic chemotherapy. And for more than 3 decades, platinum etoposide has been the standard of care, but the survival rates with platinum etoposide has not been that great. The 3-year survival rate of 5% and 5 years survival rate of 1 to 3%. This is the advances in the treatment of small cell. It has definitely lagged behind the progress as what we see in the non-small cell segment. Carbo-ito became the standard of care in 1999, platinum etoposide 1985. Then topotecan was introduced in 2007. The IOs started getting populated into small cell in 2018 with Nivo, and then subsequently the carbo-ito metazo data, and then now we have the the platinum etoposide with Durva data in 2019. Slowly, IOs are getting into small cell lung cancers and trying to make inroads to improve the overall outcomes. So this is the entire progress, which is given in a different cartoon, saying that we are from 2020 onwards, we are seeing more IO in small cell lung cancers. This was a typical treatment option for small cell lung extensive stage, 4 to 6 cycles of a platinum etoposide, sensitive or resistant disease, relapse. If it was sensitive, they would go back to a platinum re-challenge. If it is non-sensitive, they go to a non-platinum like an irinotecan or a topotecan based therapy. Now this is slowly changing now with the introduction of IO from 2018 and 19. Now we have 2 drugs which are approved in the front line. That is the focus of today's discussion. And also we can try and see how we can select one drug, one immunotherapy, one IO drug over the other. We have the atezo-carbo-etoposide as a category 1 recommendation, and the carbo-cis etoposide and a durvalumab, that is infancy, as a category 1 recommendation. So this is the atezo. This is the data of. We see that most patients of small cell, when they receive the first line therapy, they get a good overall response rate to the tune of 60 to 70%. The issue is they progress within 4 to 6 months, and resulting in an poor overall survival with a median OS at 7 to 12 months and 1 year OS at roughly around 40%. So using the most effective treatment at the first line is very, very empirical, so that very, very important, so that we push more patients into second line and third line therapy, and that's how we get the best out of each patient. So now with the 2 approved drugs, atezo and the durva, we will try to dissect out the data from both the studies and try to conclude which could probably be our first line option in extensive stage small cell lung cancer. Let's focus first on the first published data, that is the atezo-carbo-ito. It had an overall response rate of 60% and a median PFS of 5.2 months. Here, the most important point to note is the curves after 2 years. They're actually trying to cross. So This is not the first year and the second year Kaplan-Meier curves are good and comparable with the Durva, but then the curves after 24 months are closing down. This is a concern. We have data with Atazo only for 2 years, 2 years survival data of 22%, and the curves have started to close. The comparator arm curves have started to close with the Atazo arm. So with Atazo and platinum etoposide combination, we have limited 2 years data with a 2 year survival of 22%. Now with that, we will focus on the Caspian study, which is the IO chemotherapy, that is the infancy platinum etoposide combination, which is given as an induction phase and followed by an infancy as a maintenance phase once in 4 weeks. This is a 3-arm study. One arm had a standard of care, which is platinum and etoposide at 4 to 6 cycles. And then one arm had infancy plus platinum etoposide. And the third arm actually had an investigation agent, which is the CTLA-4, which is the tremelimumab, which arm was discontinued in view of more AEs and then deaths with questionable efficacy. So the discussion for majority of the discussion, what we'll be doing is a comparison of the standard of care platinum etoposide versus the infancy platinum etoposide. It is important to note that the primary endpoint was standard overall survival. Key secondary endpoints are PS, OS at 12, and TFS at 6 and 12 months. It is also important to note that Caspian allowed either of the platinum, either the cisplatin versus the carboplatin, whereas the Atazo trial had carboplatin. Patients with asymptomatic brain metastasis were part of the trial, whereas in Atazo trial, only treated brain metastasis were allowed. The control arm was allowed to take up to 6 cycles, and PCI was allowed as per the investigator discretion. So this brings us to an important point that the control arm was given the best possible treatment in terms of the full 6 cycles of platinum etoposide. As compared to the Atazo trial, only 4 cycles were allowed. Here, 6 cycles of platinum etoposide, and also PCI was also permitted as per the investigator discretion. So this is comparison of the IM-133, which is nothing but the Atazo carbo-eto, versus the Caspian, which is nothing the infancy trial. So here in IM-part, carboplatin was only carboplatin was allowed. Here, both cis and carboplatin. So here, patients with treated brain metastasis, here asymptomatic brain mets were also allowed. Only 4 cycles of EP were allowed here. Here, full 6 cycles of platinum etoposide were allowed in the Caspian study. So if you look at the Caspian study, it was a positive study in terms of the median OS at 12.9 months, versus the comparator was 10.5 with a hazard ratio of 0.71. What is important to note that this trial, we have a long-term data at 36 months. With the IM-133, we had data up to 24 months, and the curve started to close down at 24 months. Here is a trial which has a 3-year data, and almost 3 times more patients are alive in the infancy platinum etoposide arm at 36% at 36 months. It is 5.8% versus 17.6%. A typical story of an IO drug where the curves tend to be separated for a long time. So infancy plus platinum etoposide combination improved the estimated percentage of patients who are alive, with 3 times more patients who are alive at 3 years as compared to platinum etoposide. And there was a clear separation of the curve, and which is sustained with a notable flattening. The flattening actually started at 27 months, and the flattening continues at 36 months. So infancy is probably the first and only IO drug which has a sustained long-term benefit at 3 years. So IM-133 does not have this 3-year data. So if we compare the Jura and Eto, and some of these will help in making the choice. What is heartening to see is the identical data from both these trials. That gives me a lot of confidence to use the IO in extensive stage small cell lung cancer. Look at the response rate: 52.8 in the Jura arm, 51.9 in the Atazo arm. 2-year OS at 22.9 and 2-year OS of 22%. These are identical data from two different IO trials. That gives me a lot of confidence in using IO in the extensive stage small cell. The only thing the Atazor group is lacking is the 3-year OS data. Here, the durvalumab has the 3 years OS data at 17.6, whereas the comparator platinum etoposide was at 5.8%. So the benefit was seen across all the groups. You can see that most of the forest plot, most of them were to the left of the unity, and compared to age, performance status, smoking, presence or absence of brain metastasis. So Imfinzi was the first approved IO to improve both the response rate and the durability of response at 24 months. If you look at 24 months, from a durability of response point of view, it was 13.5 versus 3.9%. So Imfinzi plus EP also demonstrated a sustained improvement in PFS. As Amit was pointing out, most of the chemo plus IO drugs, the median PFS will not, at the median PFS will not show the improvement. Here also, Imfinzi plus EP was at 5.1 versus 5.4. But when you looked at the specific PFS points at 12 months, 18 months, and 24 months, that's where the story lies in. At 12 months, it was 17 versus 5%. At 18 months, it was 13 versus 4. And at 2 years, it was 11 versus 2.9%. So almost 10% of the patients were ongoing with the treatment at 3 years. Now, here is a disease which has very dismal outcome. You still have 10% of patients who are continuing with treatment with Imfinzi at 3-year data cutoff. So if you look at OS from a brain metastasis point of view, it did not matter whether the patient had brain mets or not. Patients without brain mets had a median OS of 12 months versus 8.8 in the EPR with a hazard of 0.69. If you look at without brain metastasis, the median OS was 13 versus 10.5 with a hazard ratio of 0.74. So it was looked at from an AE point of view. As we all know, chemo plus only PD-L1 inhibitors is very well tolerated. The issues start when you add actually a CTLA4 inhibitor. That's where the third arm got into trouble, and then that is not being discussed at this point in time. So the AEs are almost all comparable with the standard, except that immune-related AEs were a little bit higher on the Imfinzi EPR. So at 36 months also, there were no new safety signals, almost expected toxicity profile. So from a quality of QOL point of view, a lot of scales were used. From a cognitive functioning point of view, emotional functioning, physical, all of them remain left to the unity, favoring the Imfinzi EPR. So this was also looked at from a delayed time to deterioration in symptoms, including dyspnea, appetite loss, pain, fatigue, and cough. All of them also remain left to the unity, favoring the Imfinzi EPR. So Imfinzi also is the only IO in extensive stage which allows a 4-weekly dosing in the maintenance. This is very important. The patient need not have to come that much frequently. This is a once in 4-week dosing. This is also an additional point when compared to the other IO drug. So if you look at the study design differentiated from Caspian versus the INP, IMPOWER 133, all comers were included in both study. Untreated brain metastasis was included only in Caspian. PCI was allowed only in 10% in the IMPOWER 133, whereas it was allowed in the Caspian study. Experimental arm was excluded in the Caspian. Up to 6 cycles chemo was allowed in the Caspian, or only 4 cycles. Here, both cis and carbo was allowed in the Caspian study. So Caspian study is more kind of a indicative of a real-world experience where we exchange cisplatin and carboplatin depending on the tolerance. And we also include treated brain metastasis and asymptomatic brain mets population. So the comparator arm is so strong that most of the 6 cycles chemotherapy and PCI was allowed. In spite of that, the IO chemotherapy arm was found to be superior to the standard of care. So this is the NCCN guidelines. Durva Carbo Eto and Durva Cis-Eto, as well as Atezo Carbo Eto. If Carbo Eto is the regimen which has to be used, then the Atezo is the only IO, whereas with Durva, we can use both Carbo as well as cisplatin. So in conclusion, first-line Durva plus EP has shown sustained improvement in the OS compared with a robust control arm. I just want to emphasize on that. The control arm was robust in the Caspian trial. That is reflective of a real-world scenario following 6 cycles of EP and the use of PCR. Durvalumab is the only IO that provides flexibility of choosing cis or carbo along with etoposide. Benefit with Durva EP was observed across all subgroups, including the brain metastasis. Very important, 17% of patients are surviving even after 3 years, showing prolonged survival benefit. Imfinzi plus EP provided a high response rate and demonstrated ongoing responses after 2 years, and it's 3 times more patients than the EPR. Durva offers convenient dose, monthly once dosing in the maintenance phase. Safety findings remain consistent with the known safety profile of Durva. Thank you.